We didn't read the rules, so we're going to do something different. I'm going to start, and then we've got 3 case studies. So what could possibly go wrong? We'll wait and see. So I'm going to give an introduction to the patient safety theme. The work in this theme was inspired by work we started over a decade ago. So the Engineering Design Centre was working with the Royal College of Art and the University of Surrey. And we put a report together for the Department of Health in response to a simple question: how could design help improve patient safety? And that's the report. You can find it online, and it basically says good design thinking, good systems thinking, good risk management would contribute to safer patients. To put some context behind it, when I got out of bed this morning, I'm faced with 10 micromorts of risk of unexpected death before the end of the day. So that's a 10 in 1 millionth chance that I will not survive the day. Now, if I were to fly to New York from London, that's another 3 micromorts I can add. If I go hang gliding when I get there, that's another 8. Now, if I was to drive instead from London to Cambridge, it's half a micromort. If I went to work in Addenbrooke's for the day, you can add another 5 or 10. If I were to stay in Addenbrooke's overnight, you can add 75 to that total of potentially preventable error, and that's typical of hospitals across the UK. So that sets for us the context of why we're really interested in whether we can help improve patient safety. When we try and improve systems, there's 2 things we're trying to counterbalance. 2 questions: what can possibly go wrong, and how can we do things better? Now, this is my mid-staff's truck. And in this particular case, you can see that the fight for trying to do something better to convey more bales per truck has won over the what could possibly go wrong question. So when we're engineering safer care, we're trying to get the balance of these 2 questions right. We're trying to encourage improvement, but always check what could possibly go wrong. And that forms the basis of the research within the patient safety theme. So in answering those 2 questions, we're trying to reduce risk through proactive management and cultural change. We're trying to encourage improvement in quality and safety through challenge-led systems innovation. And the case studies you're going to see later on address both of those questions. What I wanted to do, though, is to give you a few ideas of the things that underpin engineering thinking. So there's an engineering-like diagram, which is about risk thinking. It comes from a European standard. It's a very good descriptor of risk management, but not a lot of use in healthcare until you start to translate it into a set of questions which are rather more accessible. And this is what we've been trying to do, to see how we can take that concept of risk thinking and port it across into healthcare delivery. And it's about challenging the system, challenging what might go wrong, why it might go wrong, does it matter, do we do something about it? So that's one key principle of engineering. Another is design thinking. Now this has emerged as quite a well-accepted picture of design. Chaos, what a seeming chaos, followed by a period of calm. And you sort of think, well, how on earth do we design things if that's the model of design? And what it's trying to say is that there's actually a search process going on at the beginning of the process, a process of discovery. We're trying to figure out what it is the problem we're trying to solve before we take a fairly linear track to solving it. Now, another picture of design comes from the Design Council, a very famous picture called the double diamond for obvious reasons. And the first diamond is about exploring the problem. Do we really understand the thing we are trying to design? And the second one is about exploring solutions to that problem. And that's a very important principle of design thinking. It's as much to do with trying to understand that you've got the right problem as it is trying to find one of many possible solutions. It's about exploration in both cases. We also have systems thinking in engineering. And what that reflects is that for any complex system, there are many different perspectives. Now, if you look online at aerospace design, you find many pictures like this, which represents the different interests involved in designing an aircraft. And I particularly like the Rolls-Royce perspective here, where the aircraft is the engine. And for those doing analysis or production, they want things simple. And when you're designing complex systems, you're trying to understand all of those different stakeholder perspectives and draw them together in one solution. So another picture I really like about systems thinking is the naval architecture design spiral. And it comes from 1956, and it describes how you design a yacht. And around the edge, it has all the different functional perspectives, design perspectives of a yacht. And you start on the outside, estimating various parameters, and you spiral inwards until you get to the middle, using ever more sophisticated methods to design your yacht and integrate all those different perspectives in a single design. And I like that because it shows that structure of iteration, that structure of improvement towards a goal. So systems thinking is balancing multiple requirements of multiple stakeholders together to come to a single solution. So we have risk thinking, design thinking, and system thinking as two really underpinning elements of engineering. But there's a fourth thing that we're trying to do in this theme, which is critical to these three, and that's systems mapping. We can't assess risk systematically if we can't describe the system. We can't design if we can't describe the system we're designing. We can't do the systems thinking if we cannot map out the stakeholders or the complex pathways. So what's emerged in the theme is a focus, a very sharp focus on how do we map systems in healthcare. Whether it be right from the top down, the health and care system, as in this picture, or a particular pathway at a much lower level. The key question is, how do we draw the pictures? What is the language or set of languages we should be using to describe the complexity of healthcare systems, and how can we draw those pictures? And we have to get this right for all the other three areas to work. So at this point, I'm going to hand over to colleagues, and we're going to go through three case studies. The first is on system safety assessment, and Terry is going to present that one. That's about risk methods being taken out into practice. Then we're going to look at reducing never events, and James is going to talk about a particular project in Addenbrooke's, which brings together systems thinking, design, and risk. And the final one, Ian is going to present work, again, we're doing with Addenbrooke's, which is how we implanting design innovation at the heart of the trust. Okay, so that's the first bit done. Terry.
Okay, system safety assessment in mental health. This is a particular aspect of a CLAHRC, in inverted commas, project. And as you'll see later, most of the things we do within the patient safety theme, we don't have discrete CLAHRC projects. They're almost always integrated with some other activity. And I think that's in the spirit of the CLAHRC, that we're working with colleagues on the sharp end of the service delivery. So I'm presenting this on behalf of a wide team. In fact, I would say I was a minor player in this particular activity, so the real credit should go to people like Tim Bryson and James Ward. There's a particular project that this is working with, which is called Safer Care Pathways Project, and there's a website there that you can access if you want to. So the background is really that service provision is complex. I think we all know that. And making improvements to those services is very difficult. In fact, it's in the design area what we call a wicked problem. And there's a definition of wicked problem, and it has 6 aspects to that. I've just picked out the 3 main ones here that are pertinent. The first is that wicked problems have no stopping rule. That means there's no right answer, and you don't know necessarily when you've reached the right answer in, if you like, scientific terms. Solutions to wicked problems are not right or wrong. There are multiple ways of producing answers, multiple ways of producing improvements, and none of them are right or wrong. Some are righter and some are wronger than others, but there's no easy way to say whether it's right or wrong. And every wicked problem is essentially unique. That means that we can't just take one solution from one area and simply implant it. There's always some sort of translation that needs to go on. If there's no if we have a wicked problem, we have these no stopping rules and no right or wrong answer, we actually need a currency to negotiate how we're going to try and solve that problem. We need a currency to be able to look at different solutions. And the way that we've approached that in this particular project is to use a currency of risk. Okay, now, that could be patient safety risk, it could be financial risk, it could be many types of risk, but the concept is basically of risk. So we're setting this within mental health services, and mental health services generally know that their basic currency is of risk, particularly patient risk of suicide, risk of absconsion. A lot of it is based around risk. So in mental health, I think they understand that idea of risk. We also need to find ways of dealing with complexity, and simplification or abstraction is itself defeating because the problem itself is complexity. So if we try to carry out our design work, our research work, by simplifying, we're just removing the thing that we're trying to deal with. So we have to deal with that complexity. And the way that we're dealing with the complexity, as John has said, is work from a concept of design. And that deals with both the wicked problem and we can incorporate that currency of risk. So the proposed approach is to apply risk-based design to services. And we've called this systems safety assessment. As I mentioned earlier, we don't have discrete projects. And this tries to describe how this particular project is working in simple terms. On the left, we have a CLAHRC project, PSO4, which is run by James Ward, on understanding risk. So the research issue is, how do people understand risk, how they deal risk, how do they incorporate it into how they provide services. And we're talking here not necessarily about clinical risk, although it could cover that, but the risk of things going wrong in complex services. And on the right, there's a fairly large project that's sponsored by the Health Foundation called Safer Care Pathways in Mental Health, that's very well run by Tim Bryson. And this has effectively an implementation theme. So it's about doing stuff better within a service environment. And where this particular project sits is in the middle there. So system safety assessment in mental health is the overlap between those two. And this feeds backwards and forwards into both of those projects. There are things, legacy work, training tools. There's also some human factors work that's going on within the Safer Care Pathways in Mental Health project. And there's a substantial part on evaluation. The Health Foundation are very keen on evaluation. So, quickly go through the objectives, because I feel as I'm running out of time. What we want to do is apply second-generation system safety assessment tools. The system safety assessment was developed a number of years ago on the back of a Department of Health project, but we knew it was in some ways flawed, and we need to make it more operational. We need to understand how the participants interact, understand how the SSA tools fit into the broad approach to quality improvement. So we're looking at this from a systems perspective, not just trying to isolate our tool from that system. And we want to evaluate the tool's use from the participant's perspective. Some of the design principles we can employ are, for instance, how desirable things are. So a design criteria might be, do people find this approach desirable to use? Because if they don't find it desirable, if it doesn't fit with their own schemas, then they probably won't use it. So it's not simply about the technical side of things. We've got to make sure that it's useful, usable, and more importantly, people want to use the tools. Finally, we need to evaluate the tools for safety improvement interventions. So what we did, lots of workshops. Large immersion event with 64 people, 5 process mapping workshops, 5 what could go wrong workshops. This is John's first point. One of the first questions we need to ask is what can go wrong? So we asked that question. 5 what should we do about it workshops. That's what John said we should do. So we went and asked them what we should do about it. And service user workshops. So service users are very much integrated within this project, and we have some representatives today that have been involved in that. And here's some pictures of us in the workshops. What did it look like, the tool? Well, it doesn't translate very well here, but we do have paper-based versions, but we also have spreadsheet-based versions. So effectively, we've got spreadsheets that ask a series of questions, and you have to answer those questions in order to progress to the next stage. And the idea here is that you ask some sometimes very obvious questions, sometimes less obvious questions, but to make sure that you're getting a proper understanding of the whole project and the whole challenge that you're trying to address. Impact. Well, work is still in progress. That Health Foundation project is still only about halfway through. But what that has meant is that we've got cross-regional collaboration. On the first slide, there were lots of logos. In fact, all 5 mental health trusts within the Eastern region are involved within that project. We've got 3 universities engaged, all 3 of the main CLAHRC universities. We've had PPI, carer, and service users involved. We've had managerial buy-in at the highest levels. So all of these interactions from the trust have been signed off at the board level. Evaluations still being analysed. We do have some early data, and we've been fed some results of that, and some very loose results are, first of all, the participants preferred to have external facilitation. Our tools aren't necessarily the things that people can just pick up and use without some training and some guidance. We have to decide what to do about that. Web-based and standalone versions is being developed. So actually, the simple picture I showed of 2 projects is a little bit more complicated because there's also a Eastern Academic Health Science Network project that's developing some of the tools that we've been used into a web-based resource. In general, the participants were positive about the approach. It's not a panacea. Actually, improving services, analysing them, is very hard work, as many of you probably know. So we don't necessarily see this as an easy route to the answer. It's just the guide that makes the guidance through the complex process a little easier. And that's the end of that. I'm going to hand over to my colleague now, James Ward.
Good. Okay, my name's James Ward. I've been working with Tim Horbury at Monash University and Alexios and Ava, who are medical students at Addenbrooke's, and Vishal and Paul, who are anaesthetists. And we've been looking at reducing never events, in particular regarding a particular type of retained surgical instrument called a guide wire. I'll show you that in a moment. Never events are events that are supposed never to happen, but sometimes do. And it's been a very interesting project. It was prompted by a series of never events in 2011 at Addenbrooke's. And these were all involving retained surgical instruments. And in particular, one of these was a retained guide wire. And that's the actual guide wire that was fished out of the venous system of a patient somewhere down in their groin area. It migrated, I think, through the heart and down here. And you can see the kink here where the forceps were used to pull it out. And these guide wires form part of a central line set, or central venous catheterization set. And you can see the guide wire coiled up there in its introducer sheath. And it's used to swap between various different devices and ultimately to introduce this thing here, the catheter, typically into the right internal jugular vein, and it's used for putting in medicines and for taking measurements. Here's an example of a press release from another trust around that time. Earlier this week, a guide wire was placed in a patient by an extremely competent physician. This event was the result of a human error, which got me thinking. So is it just human error? Because if it's just human error, we can just go and maybe send the anaesthetist on a training course and maybe told to do a bit better next time, or possibly slightly more draconian measures. In 2012 or so, 2013, there was an interesting article, an editorial in Anesthesia and Analgesia, which is an American journal, written by a doctor. And they said this, sorry for the long quote, "We suspect that a lack of systems-based approaches to preventing this complication," so this was specifically regarding guide wire retention, "is to blame. Instead of engaging in systems-based thinking to prevent these never events, the medical community has usually preferred punitive approaches, including a Soviet-style re-education or retraining of those who are actually, with their patients, victims of inadequately designed systems. Therefore, systems engineers and human factors experts are needed to re-engineer the central line process to prevent retention of guide wires," which is an exciting call to action. So it's time to roll up the sleeves. If you ever meet this guy in anaesthesia, watch out. Keep well away from him. And I'm just going to repeat, that's me, by the way, in case you're wondering who it is. I'm just going to repeat John's questions that he posed earlier, and the ones in bold are the ones I looked at in particular. How likely is it to go wrong? Is this just a one-off? Because if it is a one-off, then we might as well move on. Why might it go wrong? Is it simply human error, or is it, as the article suggests, a bit more of a systems problem? And if so, what should I do about it? Is there anything that we can practically do to try to reduce the risk of further occurrences? So in terms of how likely, one of the things I did was just to look at the literature, look at the case reports. I found fairly quickly, without much reference chasing, 27 case reports around the world of this particular problem, retained guide wires. And what this doesn't tell you, of course, is how many of these are being put in, how many sets are being used. It doesn't tell you what the reporting rate is. It doesn't give you a denominator, but it does indicate that it happens at least more than once. Not so long ago, a paper came out by Vanucci, which suggests that this occurs roughly one every 3,000 or so procedures. What we didn't know was how many of these sets we were using at Addenbrooke's each year. So I did a lot of work rooting around the store cupboards and eventually came up with a figure of about 4,000 of these being used per year across the trust. So if you do some simple maths, it's roughly an exposure of one per year at the trust. And if you multiply that across NHS England, that's in the acute sector, because this is where they're typically used, about 150 per year. So if that's true, this is a significant problem. The second question I looked at was, why might this happen? And there's all sorts of different techniques. These are just some of them that we used. There's quite a wide range of things. On the left-hand side, you can see an HTA, which is hierarchical task analysis, and it just breaks down the task hierarchically of inserting one of these catheters. And it helps to support what's on the right-hand side, which is a human error assessment method or a risk assessment method. And this breaks down the task again, and you can identify the size of the risk, the types of things that can go wrong. And these sorts of things won't necessarily surprise you. Task novelty, you're not used to this particular procedure, time pressure and distractions are some of the risk factors that come out. Another thing I did was to look at lots of different sets, so breaking these sets apart, having a look at them, taking measurements. And it helped to come up with a very interesting theory as to why I think this might be happening. And it's to do with the design of the guide wire and the catheter together. And in order to test that theory, we ran some observations and interviews with anaesthetists and operating department practitioners who assist them during the procedure. And we did 17 observations. And what we found was in 15 out of 17 of these procedures, so about 90%, there was an extra step that was required to avoid the loss of the wire. And the problem with this extra step is that you might forget to do it. It requires constant attention, and very occasionally you forget to do it. And if you forget to do it, you're in trouble, because the line is placed in the neck, it's then flushed with saline, it squirts the guide wire down the line into the neck of the patient, and it's gone, and it's out of sight, and it's out of mind, and it's lost, and it's hidden. James Reason in 2002, who I think is regarded as one of the godfathers, if not the godfather, of understanding human error, wrote a very interesting paper on omissions. And looking at that paper, we published something else. We took the the three most relevant causes, we think, behind this particular incident. One of them is steps that occur after the main goal is completed. The main goal is to place the catheter in the neck of the patient, not to remove the guide wire. That's secondary, and that occurs after you've placed the catheter. So that's one risk factor. Another one is hidden objects. Well, that guide wire is hidden inside the catheter. And thirdly, distractions and task interruptions. And there's various papers on this. A paper in 2012 by Campbell in the British Journal of Anaesthesia suggests one of these distractions occurring every 5 minutes during general anaesthesia. So they're fairly common. And this prompted a second set of observations that we did. This time, 10 catheter placements, typically lasting about 5 minutes per procedure. What we found was that we were seeing 2.5 distractions per minute. So really quite a high rate of distractions. And you combine that with this risk up here of this step requiring constant attention, and you've really got quite a significant risk of losing a guide wire inside a patient. So what should I do about it? The third question. Addenbrooke's have done a number of good things. They've introduced induction training for locums, specifically mentioning this risk. There's a general heightened awareness of risk across the trust of this particular problem. And they've introduced a visual and verbal double check. Guide wire out, yes, confirmed, guide wire out, put it in the tray. And they've also documented or suggested that this wire needs to be, the removal of the wire needs to be documented in the anaesthetic record, and that's what it looks like, or what it looked like until the introduction of eHospital towards the end of last year. But the focus has very much been on detection rather than prevention. So what could we do regarding prevention? So this is some ongoing work I've been doing with a variety of people. And it's under the banner, really, of trying to make it easier to do the right thing. It's all very well adding in extra steps, but that slows people down. People might not do them because they don't want to do them, they don't see the value in them. What can we do to make it actually easier to do the right thing? So we've been working with the manufacturer. I had a meeting a couple of weeks ago with the manufacturer, and we're looking at making some small changes to the wire. There's a number of changes that we can do to the introducer sheath, and all of these are relatively quite cheap to do. And also, one theory from one of the anaesthetists is quite a sneaky one, which is increasing the size of the drapes. The theory being that if you have bigger drapes, it looks like a more important operation, and therefore people are less likely to distract you. That's the theory. I'll have to test that one. We've been working with clinical engineering, and they've offered to produce prototypes for us, and this leads quite well into Ian's presentation in a moment. And also simulations. So they've got a number of mannequins there which we could use to test out these prototypes. And of course we've been working with the Department of Anaesthesia as well. So the theatre's operations manager, the head of safety in anaesthesia, and looking at how can we reduce distractions. It's a bit of a cultural change, and also changing the technique in some of the anaesthetists. There seem to be two camps, two groups of technique for inserting these wires. So in conclusion, we used a systems approach using a variety of different methods to try to get past what I think is a slightly simplistic label of human error and try and look at what the real causes were, to come up with an estimate of the rate of guide wire loss, to look at these causes and to identify some possible solutions, which we're working on at the moment, and some of those being design-related changes. It's hard to say, but it's a theory that we've got, and it's very hard to prove it because this happens so rarely. It's a never event. So we're very unlikely to actually see it ever occurring. We'd have to run thousands of observations to see that. But if the theory's right, and I've talked to lots of anaesthetists about this, and they say it seems to make sense, then, and if these solutions actually work, then this probably does have some national, if not international, significance because thousands or hundreds of thousands of these are being put in per year across the world. And just one final point, I think there's lots of other opportunities for such a systems approach elsewhere. There's lots of other risky procedures and other sorts of never events as well. And one last slide, in terms of impact, various things there, things that are ongoing, and thank you to my colleagues and funders, Addenbrooke's and NIHR, and also my co-researchers.